If I am done quickly, then I'll try to touch a little bit on the stroke too. So spinal cord, we talked about a lot of these things already. That gives you perspective. There's the dorsal horn of the spinal cord, gray matter, ventral horn. There is the, sorry, this is the ventral and this is the dorsal. It's upside down. And the body's in front, the spine is behind. You have the dorsal nerve roots, ventral nerve roots, the dorsal root ganglia, forming of the root. This is the radical coming out of the phone. This is the root or radiculopathy that we talked about. This will be radiculitis. When there's infection, this will be ganglionopathy, this will be plexopathy, plexus is forming here, and then later on will be neuropathy. We talked about the dorsal column, we talked about the anterolateral spinothalamic tract, we talked about the corticospinal tract runs here, corticorubral that runs here, rubrospinal that runs here, and the motor neurons that are right here in this dorsal root, ventral root here. Good. So you can have gray matter disease like motor neuron disease. We already touched on it, the motor neuron disorders, the ALS, the polio, the SMA, and others. There is a white matter disease, which are the demyelinating disorders like MS and MS-like disorders. And then there is the mechanical compression of the cord. So it can be from a tumor, it could be from bleed, it could be from herniated discs, it could be from trauma, penetrating trauma, bullet injury, could be from pus, like abscess, like tuberculosis, used to commonly infect spine and cause abscess and then compression on the spinal cord. And that has a specific presentation, a compression versus demyelinating disorder. So let's look through some of these.
Hey, Dr. Bhatti, really quick. I just want to make sure.
First question, 25-year-old man who has been shot in posterior thorax, so penetrating trauma, has paresis of the right leg and loss of position vibration sensation at the right ankle. Pinprick sensation is preserved in his right leg, but lost in the left leg. His upper extremities are normal. Where is the lesion? Now, the lesion is ipsilateral for motor and position and vibration, and is contralateral or opposite side is involved for pain, temperature, and pinprick. So it's a right side of the spinal cord involved. Now, there is a concept of level. Where is the level? So far, he only tells us about leg, which means that it has to be below T12L1. So the classic landmarks that we use for localizing spinal cord level, the inguinal area will be, the groin area will be L1, and the umbilicus typically sits at T10. And then if the sternum, the lower end of the sternum, is typically T8 or T6 or T8. And the nipples are typically T4. The shoulders are typically C5. The tip of the shoulders is C5. So C5, T4, T8, T10, and then L1. And then, L4 is typically below knee. Typically medial side of the ankle is L5 and outside S1. So those are the locations of sensory areas that will tell you that, are we dealing with, which level of the spinal cord we're dealing with these lesions. So it has to be right side. So ignore all the left side option. And on the right side, it is arms are normal. So it's below cervical spinal cord. So it's likely thoracic because lumbar is all involved. So probably right side of thoracic spinal cord, but it could be, lumbosacral spinal cord is unlikely. I would say thoracic spinal cord is more likely. Let's see what's the answer. Yeah, right side of the thoracic spinal cord. So which makes sense, right? Weakness and vibration is same side, and pain and temperatures on the side. This is hemitransection. Hemitransection is called Brown-Sequard syndrome. It was described by these surgeons and military surgeons with penetrating a gun knife injury. So remember, there's a long knife that was in front of a gun, and they will poke you in the back, and that will cut half of your spinal cord. And that was classic hemitransection of spinal cord. Brown-Sequard syndrome was a very common trauma in military, First and Second World War. So this is Brown-Sequard syndrome, hemitransection. When you transect, you get the motor ipsilateral going down, you get the dorsal column ipsilateral, and you get the anterolateral spinothalamic on the other side. And then there is a band where you have loss of all senses ipsilaterally, because the spinothalamic tract requires 1 to 2 segments to transfer from one side to the other. So the left side is, the right side is going to descend to the left side or ascend to the opposite side after crossing over. So that area where the lesion is, there is things that I still haven't crossed. And that's why you get an ipsilateral band of all sensation loss. And then after that band, you get half and half. One side is vibration for perception, which is ipsilateral, and other side is pain and temperature and pinprick. Pathways, I mentioned this a couple of times. Let's quickly look at it. So the dorsal column pathway starts with the neuron. The first order neuron is sitting in the dorsal ganglia. It gives out axon down to the joints for vibration and proprioception, and then it gives the other axon that goes into the spinal cord, does not intersect with anyone, and ascends ipsilaterally all the way up into the brainstem in the dorsal column. And in the brainstem, there is the first nucleus or second order neuron where it intersect. There are two separate nucleus for two separate pathways, and they are only separated based on body region. So there is cuneatus and gracilis. The only difference between cuneatus and gracilis is that half of it is, so one of it is for lower limb and one is for the upper limb. So it's an artificial separation. It's not, there is a slight septa between the two, but it's not very significant. And transition is not clear where it becomes from cuneatus only to gracilis only to gracilis and cuneatus. And then on brainstem, after the second order neuron start, that's when crossing over happens. Crossing over always happens on second order neuron, not the first order neuron. And that's why there is no crossing the spinal cord for vibration. And then it ascends with the sensory tract, which is same for everyone. And that goes up, and that's the spinothalamic tract to the thalamus, right? That's where all sensation goes. The anterior spinothalamic or anterolateral pathway, they come into the spinal cord. Again, dorsal horn is where their neuron is, a neuron cell body. And then when they come in, they immediately interface with the second order neuron. So there's ongoing nucleus all along the spinal cord, which is called nucleus proprius. And that's where the interface happens. And as soon as the second order neuron starts, it crosses over. It takes 1 to 2 vertebral heights to cross over. And then it ascends contralaterally all the way up into thalamus. Now it does not need anything in the brainstem. So in the brainstem, to this tract, the dorsal column sensation join. So by the time it goes to midbrain, it already has everything together, all sensation of the body. And then it goes into same area of thalamus, which is ventral posterior nucleus. And there is two parts of ventral posterior anterior and lateral, which involve bulbar and lower limb separately. But ventral posterior nucleus is where all the sensation goes to, and then it goes to the cortical sensory cortex. A 54-year-old man with pulmonary carcinoma has had 2 weeks of mid-thoracic back pain. So likely metastases, bony metastases are common with some tumors, such as lung cancer and testicular cancer, breast cancer. He describes a sudden onset of abnormal sensation in his legs and difficult walking. Sudden onset means that tumor has either bled and have gotten big, or tumor has eroded the bone and suddenly the bone slipped, disc clip or something like that. So sudden onset of abnormal sensation with 2 weeks of mid-thoracic back pain. He has weakness of both legs, which are areflexic and hypoalgesic from toes to umbilicus. So everything below umbilicus, or T10, is kind of paralyzed bilaterally. So it's bilateral brown C cord, right? What process is evolving? So spinal cord compression is happening, and it's happening in the thoracic spinal cord because its umbilicus below. Its T10 level is where the lesion is. Right? So yes, the answer is thoracic spinal cord. Lesion of the left medial medulla. Now, medulla is the brainstem, the lowest part of the brainstem. It's called medulla oblongata. Now, the spinal cord itself is also called medulla, but it has a different medulla name with it. And this medulla is medulla oblongata, which is used to be considered as upper end of the spinal cord, and now we call it part of the brain stem because it has a lot of cranial nerve nuclei, and that's why we don't consider it as part of the spinal cord anymore. It's a very short segment, not a lot. And then pons start, and then above pons is midbrain. So lesion of the left medial medulla will call what of the following results? So left medulla, but medial medulla, right? So once you know the syndrome orientation of different things, then you know what is medial, what is lateral. But the medial medulla will be contralateral, and it will cause contralateral impairment. So left will be right arm and leg. So it will be pain and temperature, not vibration proprioception, which is posterior in gracilis and cuneatus. Remember, the nucleus is behind. They haven't joined yet. In pons, they will start joining. And in midbrain, they will be together. So it will be pain and temperature, and it will be rising up in medial medulla, and it will be opposite side. So it will be for the right arm and leg in the left medial medulla. So it should be C. Oh, A. Vibration. So I'm not sure. Let's see if there's an image. I don't have an image, so I'm not sure why A is the answer. It has to be posterior medulla where the nucleus I will have to see the nucleus with the nucleus R. Let me quickly Google it. So I'm correct on it. Gracilis nucleus images. So I'll have to look it up why it's medial medulla is causing. Yeah. So gracilis and cuneatus are posterior nucleus and corticospinal tract is anterior. So either the question meant the left posterior medial medulla, otherwise it's corticospinal and it's the spinothalamic tract, which should be the answer, which will be the pain and temperature. But I guess you got the point that they are separate in medulla, the vibration proprioception and pain and temperature, and not together. One is crossed. So another is not, other is crossing here in medulla, which is the arm and leg crossing at this point. So question, after a minor motor vehicle crash, a young man describes having visual loss, paralysis of his legs, and loss of sensation to pin and position below the waist. However, sensation of warm versus cold remains intact. He can only see an area of 2 meters square at a distance of 1 foot and a distance of 20 foot. He is unable to raise his legs or walk. He has brisk DTRs, but his plantar responses are flexors. Where is his lesion? So answer is none of the above, I think, because visual loss would be optic nerve, optic pathway, having, but the problem is he has a tunnel central vision. So central vision could be bitemporal heminopsia, that could be optic chiasm, but he doesn't have a conic vision. So a normal vision is cone. So if you're closer, you see small area, but that small area as you go away from the vision becomes bigger and bigger that you can see with the same piece of retina or same nerve. And that's, he has a straight tunnel vision, non-conic vision, and that is a sign of psychogenic visual loss. So if you can assume everything is psychogenic based on that, or you can say, okay, visual loss is psychogenic, but let's focus on other thing. If you look at other thing, then he has loss of sensation to pain and position below the waist. So waist will be T10. Pain and position will be, however, warm sensation remains cold intact. So that's a dorsal column damage, and it sounds like it's bilateral. So bilateral dorsal column damage, and he's unable to raise his legs or walk. So that's anterior damage, while it's dorsal column. He has brisk reflexes, which is upper motor neuron, not lower motor. And he has plantar reflexes of flexor, which is lower motor normal. Yeah, so nothing is making sense. Everything is all over the place. Some fit there, some fit there, some fit there. So based on that, I will say it's probably none of the above. Otherwise, T10 was my initial thought based on his localization. Yeah, none of the above. So it's basically psychogenic. I don't know why such a complicated question. You could have simply just, they're separately testing two different things. They're testing your ability to pick up the psychogenicity in visual loss, which is a separate question. And you're also testing your ability to figure out the arrangement in the spinal cord of the lesion. So you can say that doesn't fit. That vibration provision in dorsal column, while the motor weakness is anterior column. So that, it's too many questions in one question. Which cranial nerves are covered totally or partly by CNS-generated myelin? So that's an important information to know, that the myelin cells inside the brain and outside the brain are different. So you have myelin cells that make myelin for peripheral nerve are separate peripheral myelin cells, and they there's a lot of differences. And the myelin is produced by oligodendrocytes inside the brain. And one big difference, for example, is that one cell in brain provides myelin covering to multiple different neurons, while the Schwann cell, the peripheral myelin cell, provides covering to one nerve axon only. And the covering is nothing but the cell wrapping itself around. So the covering, the myelin, is basically the bilipid layer of the two borders of the cell, with or without any fluid between them. Probably there's some fluid between them. And those two layers of the cell wall are just wrapped around. So it's a cell wrapped around, and which is different. So the optic nerve is considered an extension of the brain because it has CNS-generated myelin, while all the other nerves like facial, acoustic, trigeminal, all of them are are not extension of the brain. They are nerves. That means that they do not have the CNS cell. So optic A will be the answer. I'm not sure about acoustic, but the way the answer is written, I will go by A. Yeah, so A is the answer. is optic and acoustic. I didn't knew about acoustic. I'm not still sure, but for sure, optic nerve is considered an extension of the brain and has the brain oligodendrocytes covering the myelin. All other cranial nerves are nerves, peripheral nerves, cranial peripheral nerves, and they have Schwann cells. So this is the picture: one cell providing myelin, multiple segments, oligodendrocytes, while Schwann cell, single segment, not multiple segments, not multiple axon, while oligodendrocytes, multiple axon, multiple cell. So that's a big difference between the two. And myelin is just wrapping around of the cell around the axon. Now, demyelinating diseases is damage to this myelin. And of course, the demyelination when peripheral is separate, right? We talked about the peripheral nerve demyelinating disorders, acute inflammatory demyelinating neuropathies like Guillain-Barré syndrome. But the demyelination in the brain is separate because that's oligodendrocytes, separate disease. And we have multiple causes of demyelination in the brain. Toxic metabolic damages can cause demyelination, like the central pontine myelinolysis is an osmotic demyelination, where the changes in the sodium concentration in the body too quickly make these sensitive oligodendrocytes burst open and causes demyelination. And that is carbon monoxide can cause demyelination, radiation. There is also fatty disorders, fat metabolism disorders, like leukodystrophies, where the fat is not being recycled well. Now, myelin is mostly lipid bilayer of the cell membrane and wrapped in two double layers, like two tissues, and wrapped multiple times. So you need a lot of lipid metabolism to recycle that cell bilayer. And any lipid storage disease will lead to myelin disorders. Granulomatous diseases often predispositionally cause demyelination in the brain, like sarcoidosis. And then infections can cause demyelination in the brain, like progressive multifocal leukoencephalopathy is a JC virus infection. PMLN causes demyelination in the brain. Lyme can cause it. HIV, HDLV can cause. HDLV is more demyelination in the spinal cord, but is for the motor neurons and other pathways, but not, they can cause neuropathy, but not commonly. But what we will mostly focus on and get questions on is the inflammatory or immune disorders causing demyelination, and the hallmark is MS, multiple sclerosis. Optic neuritis usually is a first attack of MS, although there's an isolated optic neuritis that never go on to become MS. There is optic neuritis that has long segment demyelination, transverse myelination of spinal cord, transverse myelitis, and that is called the NMO, neuromyelitis optica. So it's a very special type of optic neuritis, and very special type of transverse myelitis is considered a separate disease. Those three are the mainstay of testing and conditions. Others are not very often. The only one or two question you might get is on ADEM, which is acute disseminated encephalomyelitis. So it's an inflammatory demyelination in encephalo, meaning brain mostly, and myelitis, spinal cord. It's disseminated, diffuse, and is acute. It is seen in kids. It's seen para-infectious or post-infectious. So kid had some viral illness and afterwards present with severe diffuse inflammation inside the brain. Something triggered, and now suddenly they have an autoimmune severe diffuse infusion. It causes encephalopathy because whole brain is involved. So they are confused, disoriented. They have poor arousal, so might be obtunded or comatose, confused. And they can have headaches. They can have visual problems, but they're delirious and are very out of it. It's often self-limiting, but you can rapidly improve by steroids, high-dose steroids, and is usually monophasic, happens one time, and usually does not recur, although there are exceptions. So that is, so kid present after a viral illness, chest, cough, respiratory illness, and now is encephalopathic, confused, disoriented. They may show you an MRI, they may not show you an MRI. That answer is ADEM. And it does not require ongoing treatment. You just treat acute phase with steroids, and then they'll be fine. And usually they heal pretty normally, and they're fine afterward. The bigger problems are MS and NMO and optic neuritis or clinically isolated syndrome. And then others are less common and not usually asked. So this is MS. This is the autopsy. This is a spinal cord, and you can see the basilar artery and the two vertebral arteries that are joining to form the basilar artery. And one vertebral is smaller than the other, and then they have the posterior inferior cerebellar artery coming out pica. Then you can see the spinal arteries that are coming out, the two posterior spinal arteries from the two vertebral arteries, and then joining to form one single posterior spinal artery. This will be then the dorsal column of the brain stem, and this is the central canal. The gray matter should be around here as an H. That is not very visible, but you can see area of loss of white matter. So this is the demyelination. The white thing is often from myelin that you see in the white matter, and this gray area is demyelination. It is a plaque, like a single isolated patch, and it leads to scarring. So it's sclerosis. So sclerosis and plaque used to be the old name for this MS, multiple sclerosis, that we call. Again, multiple sclerosis means the same thing. Multiple sclerosis of plaques of scar tissue. And the spinal cord can have all of these multiple plaques. This is, of course, an untreated bad disease on autopsy, so that's why there is so much involvement in the spinal cord. But each of the plaque is a small segment. Usually it's less than 1 vertebral height. There may be multiple of them. Sometimes they're confluent, meaning next to each other, and it may look like a longitudinal involvement, but it's usually separate plaques that are present. The most common initial clinical presentation and then later on is optic neuritis. 20% of the attacks of MS are in optic nerve, which is an extension of the brain. The other common presentations are sensory disturbance, 33% of the time, upper motor neuron syndrome, one limb, other limb, 13% of the time, even bulbar. You can have INO in 7% of the cases. That's why INO is tested so much. It's a very complicated and very confusing kind of a syndrome. Very easy to understand, but once you understand, very easy to test, very easy to pick up on patient. So as if I say a patient, see a patient with INO on examination, I get it in a minute, once you have understood it. But it takes it took years for me to figure it out to get it and not forget it. But it is 7% of patient attacks are INOs. They have intranuclear ophthalmoplegia. That's why it's always on the exam. So this is INO. And INO is basically loss of confluent movement of the eyes, congruent movement of the eyes. So there is conjugate movement of the eyes move together. That's called yoking. The eyes are yoked together. So any signal to move the eye is given equally to both eyes, and it's adjusted so that if one eye needs more movement than the other, or more strength, then gets more signal, so that both eyes move congruently. So the goal of the brain is to make sure that the spot in the vision falls on the same spot in the retina of both eyes. So that has the same brain representation. Otherwise, you will get double vision, diplopia, right? Now, loss of this congruent movement together, loss of this yoking, is intranuclear ophthalmoplegia, where one eye moves and the other doesn't move. That's the easiest thing to remember. Now, why would it happen? Sorry, can we drink some water? Again, I'm explaining it because it is often on the exam. So that's the challenge, and that's why I'm explaining it. So the reason it will happen is that the eye movement, conjugate movement, is through different nucleus, right? We have the third nucleus, which controls most of the eye muscles, but then there is fourth and sixth, which control one muscle each, which is separate. The main one here is the sixth nucleus. The sixth nucleus moves the eye out, lateral adduction, which is an important movement, because anytime you move the eye, you need lateral adduction of one of the eyes, either one eye or the other eye. Even if it's a mixed movement, it's up and out and up and down, even if it's not pure horizontal movement. Pure vertical is when you won't need it, but those are uncommon. Pure vertical movements are very uncommon. Usually there is some lateral component, such as tracking or looking at someone or answering a conversation. So the one movement is from sixth nerve, and one is from sixth nerve nucleus, and one is from third nerve nucleus. And both of these nucleus are not together. They're away from each other. If they were touching, then maybe they could just tell each other that, I'm moving, you move, right? But because they're not touching, they are away from each other, there needs to be a connection between the two to tell them that one tells the other that I'm moving, move. And that connection is called MLF, or medial longitudinal fasciculus. So it's medial in the middle, medial side. It's longitudinal, straight. It's a fasciculus, means a thin bundle, very thin bundle. That's why it's called fasciculus. And fascicle is a thin bundle. So medial longitudinal fasciculus is just a thin bundle of connection between the third nerve nucleus and sixth nerve nucleus. Now, interestingly, the movement center for conjugate movement is in or right next to the third nerve nucleus. And the sixth nerve nucleus is just given the command. So the third nerve nucleus is what decides, okay, I need to move together. The information has come together. And the third nerve nucleus is trying to coordinate the movement with the sixth nerve and sending signal to the sixth nerve. And because there's a distance between the two, there's a lag. There's a microsecond lag between the two. But that's enough for a fast movement. If a car goes by fast, often it becomes blurred or double because it may be beyond the capacity of the eye to coordinate. Coordinate synchronicity, because you want the car moving vehicle to be on the same spot on the eye retina, and you can't do it. You lose it if you don't move fast enough. And because third nerve needs some time to send information to sixth nerve, usually it adjusts for it. So there's some prediction involved. The third nerve sends some prediction to sixth nerve that, okay, I'm moving, I'm going to be here in 1 microsecond, and that corrects or adjusts for the lag between third and sixth nerve communication. Anyways, too much information. Myelin longitudinal fasciculus, if it's damaged, there is loss of coordination between the two, or there's delayed coordination, because usually MS is a demyelinating lesion. The axons are still there. They have just been demyelinated, so they're slowed. So what happens is that fast connection between the two is gone, and even that minimal correction that the third nerve nucleus was doing to sixth nerve in timing is gone. And now the timing is off. So the one eye move and the other is behind. It doesn't move together. And that creates a very specific phenomena, which is called INO. It's even more clinically complicated because the MLF is often not damaged isolatedly, but is often damaged along with the third nerve nucleus, right where that motor control is, which is right next to the subnucleus and third nucleus for medial rectus. So what happens is that you not only have a lag between one eye and the other, you also have one eye not able to move the medial rectus. So you have two problems, not one problem. One problem is just a lag on looking to one direction. The other problem is that the one eye just doesn't even move to the other direction. And that is called 1.5 syndrome. I'm not sure which of this is one and which one is a half, but it's called 1.5 syndrome, which means that the one eye just doesn't look at one way and the other eye is slow in following the eye to the other way. And that is why it's called 1.5 syndrome, which is damage to MLF and third nerve nucleus at the same time. And all of these come in exam, and that's why I had to go through this unfortunate technical detail. All right, Uthoff's phenomena, rarely tested. It's a phenomena where in multiple sclerosis, there is worsening of symptoms because of heat, either hot shower or from hot day. And that is because the heat impairs the conduction through demyelinated axon. So although remyelination is going on, remyelination is not complete. The demyelinated and remyelinated neurons are thinner myelin than the rest of the neurons. And that's why that myelin doesn't protect them from heat affecting the conduction. And that's why you get the Uthoff's phenomena. The hermit sign is a sign where a sudden bend of the neck gives a electric shock-like sensation along the spinal cord on the back. And that again is seen because of the sclerosis, the scar tissue that is kind of anchoring the nerve. And the nerve get irritated when the scar pulls on the nerve as you bend your head. And that's the Hermit sign. Both of these are common phenomena and often tested in exam. MRI plaques, you may get an exam on it. There are certain features about MRI white matter lesion that are MS related, because seeing white matter spots is not unusual on MRIs, and we often see chronic white matter disease on MRI report. Why it's a chronic white matter disease and not MS, and that is some of these features of what an MS plaque look like compared to white matter disease. The MS plaque is usually along the periventricular spaces next to the CSF space. So they will be either in corpus callosum right next to the vertical, or subcortical, juxtacortical, we call them, right next to the sulci, on the depth of the sulci. So these are the common location, either periventricular or juxtacortical. The other thing is that they're usually vertical and directed towards that space. So if you look at the CSF space, they're vertical and pointing to that space. So it's like a vertical penetration of CSF suspended antibodies or something is causing these plaques. And that's why they look this way. And that's another way of telling them that these are likely MS plaques. And they predominantly affect corpus callosum is a third thing to remember in exam. All right, 24-year woman woke up with dry, itchy eyes, vision mildly obscured, and gradually the pain increased and the loss of vision increased, and she had to use the other eye. Next day, she couldn't tell at all with her affected eye, meaning the vision is gone. And when you are doing the exam, you see that one pupil doesn't react. Remember the swinging torch reflex? Now the swinging torch reflex comes in, that when you shine the eye on one eye, it contracts, which is a normal eye. And when you take it to the other eye, where the vision is gone, it dilates. It dilates because it has contracted some when the light was in the other eye, which is a normal eye. The brain was perceiving it. So even the abnormal eye that is not perceiving the vision still has some contraction. And when you bring the light back in the swinging torch, the pupil dilate. And that dilating pupil tells you that there's an afferent pupillary defect, that the light is not going in to the brain. And that's a way to verify that the vision loss is a real absolute vision loss or complete vision loss. And that tells you that there is something in the optic nerve. And that is also important because when you do the fundoscopy of these patients, the eyes are great, normal. Fundus is completely normal, completely fine. There's nothing there. So the patient sees nothing and the physician sees nothing. Used to be a very famous sentence in the past. And that's optic neuritis. So this is a swinging torch reflex. And when you do the MRI, you see the inflammation of the optic nerve. Optic nerve is an extension of the brain, has the same myelin, and it may be the only lesion. So it could maybe the clinically isolated syndrome if it's clinically present. If it's not clinically present, it's a radiologically isolated syndrome. But in this patient, you're also seeing a lesion here in the spinal cord, thoracic spinal cord, and one lesion up here. Both of these lesions are less than 1 vertebral body height, which is important for MS, that they are not very long lesions. So that's why they are MS. And you will start therapy to prevent more attacks from happening. The current attack that's ongoing, you can treat with steroids. It will speed up the recovery. The amount of recovery is the same in a group of people, regardless of whether they receive the steroids or not, on average. Individually may be different slightly, but the speed of recovery is much faster with steroids. So acutely you give steroids just to speed up the recovery. But then the treatment is to prevent more attacks from happening because it's a remitting, relapsing disease. Another one is the main difference right away. You can image, you can see that the spinal cord is now much more extensively involved. So this is different than the MS lesion we saw before. It'll also look more angry, almost looks like a tumor, that there is a swelling of the spinal cord in that area. There's a big dark white blotch in the center, and there's a long extension above and below it. Now, this is not MS. This is what is called NMO, or neuromyelitis optica. So neuromyelitis optica is different from MS because it causes optic neuritis and longitudinally extensive transverse myelitis. It is more severe attack. It is less responsive to steroids. It does not always heal completely, and it may be a long, prolonged event and may not come back, but that event would likely lead lifetime deficits. And we often treat them more aggressively. Sometimes we do plasma exchange or IVIG or rituximab and things like that. And that will be the NMO. And there is an antibody, by the way, that they sometimes check for. It's IgG antibody to aquaporin 4. Aquaporin 4 is a water channel. It is specific for myelin in optic nerve and spinal cord, and that's why you see this disease. And it's 90% specific, but only 75% sensitive. A third or a quarter of NMO patients don't have IgG and aquaporin 4 positive, but you can send this test for patients. This is ADEM that I mentioned earlier, acute diffuse encephalomyelitis, a lot of big lesions, and it will cause severe encephalopathy. Young kid, usually less than 12 years of age, and usually after a viral illness, that they had a fever, a couple of days, missed the school, had a cough, recovered through the weekend, and now coming with ADEM, acute diffuse encephalopathy. Of course, you'll do a full viral workup and everything. It could be VZV encephalitis, it could be HSV encephalitis, and so on and so forth. So, you usually do a full workup. I mentioned the central pontine myelinolysis. There's occasionally a question on it. It is demyelination that happens due to osmotic demyelination from rapid correction of sodium, seen most commonly after alcoholics who come in with hyponatremia, chronic alcoholism. You give them normal sodium saline, and their sodium corrects rapidly, and that causes a problem. There's a rate of correction, but I don't think they will ask you that. So just image or recognizing it will be important. Sometimes they give this image of it's always in the pons. So it's a central pontine myelinolysis. It can happen extra pontine. Sometimes they ask that question, like, can it be seen in other areas of the brain? Yes, the answer is yes. All right. So I